Bismillah ar-Rahman ar-Rahim. Today we will discuss the first half or the first part of management of insomnia. Inshallah, next lecture we will talk about CBT for insomnia and sleep hygiene, which both considered as non-pharmacological treatment of insomnia. Just to a gentle reminder about the definition of insomnia. It's very important to know that it is not only a matter of decrease or in quantity or in quality of sleep. It is also related to the environment and adequate circumstances to get sleep, and to that this insomnia will result in daytime impairment. Of course, sleep hygiene will deal with the environment. It's very important. The environment surrounding anyone before sleep, during sleep, this is very important. We'll discuss next lecture, inshallah. Okay. This is the criteria. We no need again. This is very important. The sleep-wake cycle. We have two important drives that control our tendency to sleep. Why we are sleeping at night? What are the causes that make us sleep? Number one, the blue line, if it appears, this is the homeostatic or sleep drive. Homeostasis. Homeostasis, as I mentioned before, that during working days, all of us can sleep late at night, and we have to wake up early in the morning to go to our work. Okay. During the weekend, we have what we call it homeostasis. What is deprived from our sleep during working days, we have to regain it, and we sleep more time during weekend. Most of us will wake up too late on Friday or Saturday because this is because of the homeostasis. Homeostasis also means, as you see, this I try to do it with mouth here, the arrow of the mouse. Here it is 7 a.m. in the morning. You start to you are active, and some metabolite will accumulate, some chemical. It will increase, okay, until 11 p.m. This metabolite, for example, adenosine, like we said before, adenosine will accumulate, and at that time we have to start sleep, okay? But what about the next drive, which is very important, the circadian rhythm, the biological clock? It is very important, okay? Here, if you notice, this rhythm, we during light, through the day, we are active and alert, and at 11 p.m. our melatonin will be secreted, and we will get asleep. As you see here, both homeostatic drive and wake drive, both of them will act together in spite of different performance, but both of them will lead to start of sleep like it appears here at 11 p.m. normally, okay? We said this before, but let us remind us, because this is very important regarding treatment. As you notice here, the arousal system, it depends on more than one neurotransmitter: acetylcholine, norepinephrine, serotonin, histamine. All of them will lead to alertness and wakefulness, okay? And the maestro of all of these neurotransmitter is orexin. As I said before, orexin will be the maestro for all the neurotransmitter responsible for wakefulness, okay? This is very important to remember. We have three important receptors. By the way, most of our psychiatrists know this very well, that any psychotropic medication that will lead to blocking, again, antagonist or blocking the action of alpha-1, which is adrenergic receptor, as if we block the action of norepinephrine, M1 muscarinic receptor, which is a receptor of acetylcholine. So if you block muscarinic 1 receptor, which is for acetylcholine, H1 histamine 1 receptor, we just saw in the previous slide that acetylcholine, norepinephrine, and histamine are responsible for wakefulness. So any medication that will block alpha 1, M1, H1, that means block acetylcholine, noradrenaline, or norepinephrine, and histamine. This will lead to sedation. And this is very important. A lot of, especially atypical antipsychotics, will block all of these receptors. This lead to sedation, orthostatic hypotension, lead to weight gain, especially H1. So these receptors are very important, okay? So simply, I think over the counter, as we will see, antihistaminics used to induce sleep, okay? That's why by blocking H1 receptor. Pharmacological treatment of insomnia, we will talk about 4 different classifications. FDA approved medications, off-label treatments for insomnia, over-the-counter, and herbal treatments. The FDA approval, we have benzodiazepine receptor agonist. These divided into 2 important groups. Benzodiazepines, which is unfortunately, benzodiazepine is not benzodiazepines are abused or misused by a lot of patients. Most patients came to you, I can't sleep, please give me sleeping pill, I want to sleep immediately, even not at night. When they came in the morning OPD, they ask you to give him tablets to go back to sleep immediately, because I can't sleep for the last 3 days, for example, okay? This is a big problem. The other group, which is slightly better, but unfortunately has the problem of high tolerance. Yani, a lot of patients get benefit from the second group, which is NBBRA, non-benzodiazepine receptor agonist, okay? So they are acting like benzodiazepine on benzodiazepine receptor, but in different way, okay? We are called them Z drugs because we have 3 or 4 of them. All of them start with the letter Z, okay? Z drugs. We will talk about them. Melatonin receptor agonist, by the way, this is very important. We have only one FDA approved melatonin receptor agonist medication for sleep, which is Rameltion. Melatonin by itself, that you can buy it from pharmacy, it is not FDA approved. It is a food supplement, okay? And by the way, it is written and included in all textbook of psychiatry. But by the way, if they are misused, the melatonin, yeah, maybe it's surprising to you that it may lead to infertility, both in men and women, okay, if extra used, okay? And I think anyone, you have even synopsis of Kaplan synopsis of psychiatry, if you try to read melatonin, you will find that this is one of the, actually it is not common, rare side effect, but it could happen and reported that it could happen, okay? Tricyclic antidepressant, the only one who considered FDA approved is Doxepin. We have it here in our hospital under the name of Sinequan. Sinequan, it is 25 milligram tricyclic antidepressant, it include high antihistaminic effect. That's why, as we will see, in the US, it is available not as tricyclic antidepressant 25 milligram form. No, it is also found in 3 milligram, very small dose, to use the antihistaminic effect without using the tricyclic or antidepressant effect, okay? Barbiturates, of course, in the past was FDA approved, now obsolete, of course, because of high tolerance, high dependency, hepatotoxicity, a lot of problems. So barbiturates now obsolete. And orexin receptor antagonist, I think after showing that the orexin is the maestro of wakefulness, if I block the receptors of orexin, so suppose that I get a better sleep. Okay.
Available, Dr. TAREK?
Not in Kuwait. It is available in US and some European countries, but they use it. And I asked one of I think in Dubai there was the conference, British Association of Psychopharmacology, and there was a sleep specialist who gave a lecture, and I asked him this question: did you have an experience in using orexin receptor antagonist? He said yes. I told him we are afraid that we have narcolepsy as a side effect, because in narcolepsy orexin is already decreased. When I block orexin, suppose it will be decreased. So do this patient have any side effects like appearance of narcoleptic changes? He told me, no, we have this concern, but in the real life, this has not happened on a regular basis. These slides I will not talk in, maybe it's in front of you, but what's important for me that what are the benzodiazepines that have FDA approval to use for insomnia? You will not find Xanax, alprazolam. You will not find diazepam, which is Valium. You will not find promazepam, which is lexotanil. You will not find even lorazepam, Ativan. In spite, it is that's what I mean. It's very important to know that the types of benzodiazepines that got FDA approval, most of them are have short half-life, okay, as we will see. Florazepam, temazepam, okay, unfortunately we didn't have of the triazolam, estazolam, and quazepam. I intended just, okay, the lecture is here, you can find everything related to them, but for me, we have 5 benzodiazepines that are not used in our hospital. These are the benzodiazepines that could be used for treating insomnia. Okay, this is very important. So you cannot give just any benzodiazepine to treat insomnia, Xanax, Valium, whatever. And by the way, one of the reasons that this unit postponed all these years, I'm the head of this unit since 2012, because of benzodiazepine clinic. It will be benzodiazepine clinic. Why? Because all benzos used in our hospital, the patient will suffer from insomnia even if he used Xanax, Valium, Ativan together. So, doctor, I can't sleep. Prescribe the 4th benzo, please. This is not accepted, of course. Okay? So, again, we have 5: florazepam, temazepam, triazolam, estazolam, and quazepam.
Okay. Why these benzodiazepines not available? Because the government doesn't supply them?
Simply no one asked for them. Simply. This is number 1. Okay, this is number 1. Number 2, I think rohypnol is removed. Xanax removed from our pharmacy, then it came back with a very restrictive way to dispense it. And also, if you remember that I think midazolam, which is dormicam. Dormicam is recently removed also, because simply I remember this during our medical council. Dr. Ammar asked me frankly, did you, how do you usually use dormicam to treat insomnia? To be honest, I never prescribed it since 7 years, even for one patient, okay? And it is not reported. I didn't mention midazolam here, which is dormicam, okay? So it is removed. I think if we replace these medications, okay, with at least 1 or 2 of these benzos, if we got 1 of these 5 benzodiazepines to be available in our hospital instead of dormicam, rohypnol, Xanax, okay, and it will be written, I think, only by our unit or under the supervision of our unit, I think no one will object this idea. Okay, so we will planning inshallah to ask. Okay, the second group of benzodiazepine receptor agonists, the drugs, as you said, zolpidem. Zolpidem in our hospital is Stilnox. I think all of you know. In US it is Ambien. Stilnox is very important. We have here Stilnox. It is a white tablet. The tablet contains 10 milligram of zolpidem. Initial dose, okay, 5 milligram for women, 5 to 10, okay, no problem. You can give up to 30 milligram. Zolpidem is available here. As you see here in the in this image, Stilnox, as we have it here in our hospital, okay. What I want to let you see is on the left side. The left side, we have two problems from Stilnox. By the way, Stilnox initiates sleep. It is the best medication to initiate sleep. So if you have a patient only complaining of difficulty initiating sleep, the best medication is Stilnox. Because this patient will tell you, if I start my sleep will be continued, not interrupted. I will wake up next morning fresh and everything is okay. The problem, doctor, that I cannot initiate my sleep, okay? Stilnox work half an hour, maximum 1 hour after taking the tablet, and it will last for 4 hours. We have two problems from Stilnox. The first one, that some patients initiate sleep normally, then wake up at 3 a.m. or 4 a.m. and they cannot go back to sleep. And they come to us, please doctor, we slept very well, initiate our sleep, but I cannot maintain my sleep if I wake up early in the morning. That's why on the left side they make another form of zolpidem. It is intermeso or sublingual tablets. And you see the dose is 1.75 or 3.5 milligram, a very small dose. Sublingual, it will act immediately and it will last for 1.5, maximum 2 hours. So as if anyone wake up 3 a.m. and cannot sleep again, he will just put tablet sublingual, he will continue sleeping without hangover next morning or any problem. This is very interesting and very important. It's available in US, not here, okay? By the way, when we discuss this, I think very important that we ask for trazodone, we ask for modafinil, okay? But I think after opening our unit, we will have a reasonable list to ask. We will not ask for all medications, okay? So this is intermediate. The second important, very rare but very critical for the patients, that most of them complain of parasomnia-like behaviors. They told me when I start Stilnox, sometimes I write messages on WhatsApp while I'm sleeping. I'm not aware of that. So next morning, my friends, what are you sent last night? This is very important. Another, they said that we can go and open the refrigerator and eat something like sleepwalking or something. So some rarely happened from Stilnox. It's very important. The rest of, okay.
You're telling that the somnambulism is a side effect of Stilnox actually?
Yes.
It's a side effect of Stilnox?
Yes, yes. Like waking up, some patients complain that, okay, we initiate sleep well, but wake up early in the morning. Other patients, very rarely, but reported that I have some parasomnia-like effect, abnormal behavior, abnormal movement, while I'm not aware of it, okay? So the rest of the drugs, as you said, as you see, zaleplone and isopiclone. Zaleplone, Sonata was available in our hospital in the past, by the way. Sonata, before we have zolpidem, we have it and we use it, and by the way, it was okay, no problem. And as you see in the primary indication, the third column, sleep onset insomnia, all the drugs will be perfect for sleep onset or difficulty initiating sleep, okay? This is very important to compare benzodiazepine and Z drugs. The above curve, as you see, the patient have insomnia. Okay. Now this is the normal. The patient can't sleep well, have insomnia. When you give benzo, he will sleep, effective hypnotic action, no problem. But with passage of time, he will develop what? Tolerance. Okay, and this is not the only problem. If he stop it immediately, have withdrawal, and not only withdrawal symptoms, we have rebound insomnia. It is very difficult. Some people taking 3 tablets Xanax at night, and the medication they no longer available. So all of a sudden they stop taking Xanax. They become highly agitated, highly anxious, and can't sleep. They have what we call it rebound insomnia. Okay, then return of insomnia. Okay, we have either return of insomnia or recovery. What I mean here is that this is the curve of using benzo. First, perfectly hypnotic effect, so the patient becomes so happy, but unfortunately there will be tolerance and withdrawal or rebound. Here, regarding insomnia, as you see, Z drugs, the hypnotic effect is more or less longer, stable, you have perfect, but the problem is that, of course, also, and this is very important, less dependence, less withdrawal, but don't forget that if you stop them immediately, maybe there will be return of insomnia. Okay, but of course better curve than using benzodiazepine. Melatonergic agents. As you see here, we have melatonin itself. Okay, this is food supplement, not FDA approved. Mainly the hypnotic effect acting on melatonin 2 receptor. We have rameltion and tasimeltion. Rameltion is, I think, since 2010 available, FDA approved, acting on melatonin 1 and 2 receptor. And we have our antidepressant valdoxan, which is agomelatine, that blocks serotonin receptor and at the same time acting on melatonin receptor. But there is a very important fact here. Agomelatine or valdoxan, which is antidepressant, is not a sedative drug. It will not lead to sleep. It will, what we call it, it will arrange the sleep architecture, or organizing the sleep architecture and making again as if normal sleep architecture. But it is not a sedative medication. And by the way, this is, this quotation is by the Servier, by the company itself. It is not a sedative drug, because some of our colleagues give valdoxan at night aiming to make the patient sleep. This will not happen. And by the way, agomelatine have a very bad effect on liver. So before giving agomelatine or valdoxan, you have to do liver enzymes to be sure that liver is okay. So in these agents, we have the only FDA approved is the rameltion. This is the rameltion or Rosirem. It is 8 milligram available. Okay, not here. Lameltion, Rosirem, like you see, it was approved 2005 by FDA, treating insomnia. Okay. Tasimeltion, not for insomnia, to be honest, which is Hetlioz, 20 milligram capsules. It is for one of the circadian rhythm sleep disorder. If you remember when we talk about circadian rhythm very rapidly, that we have what we call non-24-hour sleep cycle in the blind people. If you remember when I told you that there will no setting of the biological clock by light-dark cycle simply because the patients are blind. So every day the clock will be delay 1 hour compared to light dark cycle. Okay, this medication in particular treating this condition. Okay, so it is not for insomnia. That's why I focused only on Rameltium. As we said, tricyclic antidepressant, Doxepin, in our pharmacy it's sine qua non, it's high antihistaminic effect. And by the way, that's why in our pharmacy we wrote it on controlled prescription like benzo, like Xanax, in spite of it is a tricyclic antidepressant, okay? And as you see on the left side, this is the medication. I told you 3 and 6 milligram. It has another name, not Doxepin or sine qua non, but it is the same. They call it Selinor. This is as antihistaminic effect of the medication, to use it only for insomnia, away from the hazards of using Doxepin as tricyclic antidepressant, especially in old age, cardiotoxic, constipation, dry mouth, a lot of problems. Okay, this is, and by the way, because of this strong antihistaminic, it's very strong. You will find this medication also in As'ad al-Hamad for dermatology, allergy. It is anti-allergic, antihistaminic. You will find it in a cream form or ointment form. Very interesting. The only antidepressant in psychiatry that could be used as a topical or ointment is Doxepin, simply because it has very high antihistaminic effect. Very high. Yeah, simply Selinor, we use it to sleep as powerful antihistaminic. To know how it is powerful, it's a topical dermatological use only, this ointment. Okay, it's very interesting. Okay, I will not I'll try to the Orexin, or its name hypocretin, the same hypocretin because it is secreted from hypothalamus. Orexin antagonist. Orexin is we have 2 types of orexin. We have Orexin A and Orexin B. Both of them working on Orexin receptor. We have Orexin A and B, so we have Orexin 1 and 2 receptor. We have some medication, single Orexin receptor antagonist 1 blocking the receptor 1, or single Orexin receptor A2, the block receptor 2, or DORA. Dr. Dora, man. Dual, okay, Orexin receptor antagonist that block both receptors. Here it is, I don't want to, if you remember the lecture about neurobiology of sleep, when I talk about Orexin, that it is not, it is highly sensitive, not only during wakefulness, it could discharge and secreted more during motivated attentive behavior. It is not only I am waking now, Orexin is high, but if I am focusing on or something or motivating behavior, it will be higher. Okay, so that's what I mean by tonic firing of Orexin during wakefulness. Okay, or phasic firing. It is very important. If you do something motivating, it will not like baseline or tonic, it will be discharged more to make you more wakeful, more alert during motivating behavior. Okay? This is the medication available. It is called suvorexant. In the pharmacy, it's called Belsomra. Belsomra 10 milligram. This is Orexin or dual Orexin receptor antagonist. As I told you, in UK and in US, they use it already and have experience in it, and they said that it's working perfectly. The off-label treatment for insomnia, rapidly, trazodone. Trazodone is a magic. We didn't know actually how it works related to insomnia, but until now, you didn't find any paper, any textbook of talking about management of insomnia, unless you will find trazodone as one of the most important things. Mirtazapine, which is Remeron, of course. Other tricyclic like amitriptyline, which is triptizol. A typical antipsychotic, quetiapine, which is Seroquel, and olanzapine, which is Zyprex. Okay. Trazodone, as you see in Egypt, for example, it's available as it's here, 50 and 100 milligram. It is very cheap medication. Maybe here more than quarter dinar, maybe 20 dinar. In Egypt, to be honest, it is a name Tretico. It is not a costly medication, but it's very effective. By the way, it is a very safe antidepressant for old age and sedative at the same time. No weight gain, low risk of dependence, low risk of sexual side effects. So it is one of the medication that we could use it. As you see here, trazodone and doxepin, this is like a comparison between them. The antidepressant dose for trazodone from 150 up to 600. To be honest, we never use it more than 200 milligram. Hypnotic dose, it is smaller. Yani, this is very important. Like Doxepin, if you remember, Selinor is 3 milligram. It is the same here. Here, this is the antidepressant dose. It is 150 maximum. And here, Selinor from 1 to 6 milligram. So what I mean here that the antidepressant dose totally different from hypnotic dose. Over-the-counter sleep aids only divided in two categories. Either antihistamine like diphenhydramine or Benadryl, doxylamine, or melatonin, which is nutritional supplement. Secondary insomnia, especially we use it, it is perfect in jet lag and shift work. Okay, these are some of the you can find it in the supermarket, whatever you want. Okay, sleep aid, Unisom, sleep well, dream water, a lot of things. Huh? Okay, so all of these over the counter you will find it either antihistamine or melatonin. Okay. Herbal treatment, and I think Dr. Muhammad was interested in valerian. Valerian, and I think you said it's maybe available, or we will ask, I don't know. Valerian, because you know a lot of our patients, please doctor, I want to sleep, but I know that your medications will lead to dependence and addiction. Please, if you have something natural, okay. Valerian, root of Valerina officinalis. Since ancient Greek and Roman type, it acts on GABA, and you know GABA is inhibitory neurotransmitter, and it will lead to sleep. Kava, it is a shrub, small tree, cultivated in Pacific Island. In 2002, FDA warned that severe liver injury may result from it. By the way, kava, it's available like tea. Yes. Kava tea, I think, or something like that. But it is, yani, take care that it, yani, okay. This is, I think, yani, you will find valerian, hops, oral drops, okay? It's like Lang association. Valerian hops, oral drops, okay? But I think if you can, yani, we will search about it, but as it obvious, yani, herbal, I think we need to yani, know it better because of our patient may get benefit from it. This is cavity, okay? Yani, just to see it, but the problem here it is written, regular consumption of this herbal tea assures sound and quality sleep during night. Of course, this is yani, from the people who use it, okay? At the end, to make it easier for us, we have a problem that if we use ultra long half-life hypnotic, very long half-life hypnotic, it will lead to a problem. I think it is very logic. It will lead to drug accumulation or toxicity. Simply, the medication you will take it in the morning. It will maybe last for 1.5 days in your blood. So next morning you'll take another one because it's long half-life. So it will be accumulated until you have toxicity. Here, as you see, this curve is very important. This is the drug concentration. As you see, as long as it is ultra long half-life, each day you will take it, the concentration increased like step ladder until you have toxicity. Here is, you can consider it the minimally effective concentration. The medication you have, this is the minimal effect to start having effect as a hypnotic. Half-life 24 to 150 hours. Examples, fluorazepam and quazepam. Okay, so these both and benzodiazepine, they have by the way, these are 2 out of the 5 benzo we talked about. Okay, but the problem in these 2 benzos, ultra long half-life. So the problem, of course, if I want a patient to sleep for 2 or 3 days, we can use this medication. Okay, but of course not for all patients. The problem, very long, ultra long half-life that will lead to toxicity. Okay, so I think we are not, will not be in need to use this as hypnotics. Okay, what about moderately long half-life medication? What will be the curve? This is the line, is the minimally effective concentration. Half-life here is only ranging from 15 to 30 hours, okay? Like estazolam, temazepam, and by the way, to be honest, if you want to choose one of the 5, temazepam is the best. Most tricyclic, mirtazapine, remeron, olanzapine, zyprexa, all these medication will lead not to toxicity, but as you said here, it will be, you will suffer the patient from hangover. You will take this medication at night as long as it's still moderately half-life. So next morning the patient will be drowsy, he cannot drive the car. As you said here, this is hangover. So ultra long half-life, the problem is toxicity. Moderately long half-life, the problem is hangover. Okay? Okay, ultra short half-life. This is supposed to be perfect. Half-life 1 to 3 hours, like I told you, zolpidem, Stelnox. It's perfect. It works very rapidly. But the problem is what? The patient may wake up early. He cannot maintain sleep. Okay? So that's why I want to let you, loss of sleep, maintenance, low level before time to awaken. Here, as you see, this is the minimal effective. So I can sleep, it decreased, sleep, okay? Each day you will make it like this, okay? It's very important, okay? Okay. Optimized duration of action. Sleep maintenance, no hangover, and this is the medical, which, the best half-life is 6 hours. Again, the ultra short, it was 1 to 3. Before 15 to 30. 24, no, we need 6 hours. Examples, izobiclone, zolpidem, CR, continuous release, not the Stelnox immediate release. Low dose of trazodone, okay. Low dose of Doxepin, okay. Low dose of Seroquel. Low dose of antihistaminic, Benadryl, like we said, over the counter. These medications are the best for optimized or for maintaining sleep. By the way, again, if the patient have difficulty initiating sleep, use zolpidem, immediate release, Stelnox. If the problem is in maintaining sleep, it is interrupted, use Doxepin or trazodone. It's very important, okay? If the patient wake up early in the morning, of course we can use Doxepin or trazodone or temazepam, whatever, but I think if we have intermezzo, this sublingual, it will be perfect, because simply there will be no hangover next day, because it's only for 1.5 hours maximum. I think this is the last slide. I think it is like a summary for all medications used, and as you noticed on the tick on the right is the FDA approved medications. Benzodiazepine hypnotics, non-benzodiazepines or Z-drug, antidepressants mainly Doxepin, trazodone, hypocretin, suvorexant or Belsomra, melatonin receptor in melatonin, rameltion, tasimeltion, and I think now you know that melatonin is not FDA approved, but it is over the counter. Rameltion is the only one approved by FDA. Tasimeltion, it is not used for insomnia, it is used for only a certain circadian rhythm sleep disorder. Antipsychotics, quetiapine, and let's talk that in US, quetiapine or Seroquel 25 milligram is manufactured for insomnia. It is not an antipsychotic, by the way. 25 milligram, this is only for insomnia. Because antipsychotic effect of Seroquel, it will never appear less than 600 milligram up to 1,200. So 25, it is not an antipsychotic medication. Anticonvulsants are clonazepam. Here you can find clonazepam, Rivotril. Of course, we can use it. Gabapentin, triagabalin, and pregabalin, which is Lyrica. Of course, it is not written here because some patients came to us. I need Lyrica to sleep. No, this is not recommended for insomnia. Thank you.